Last week, we talked about a study from the Journal of the American Medical Association, which talked about more profit for hospitals when there are complications to surgery. And joining me to talk about that is Dr. Andrew Gonzalez. He's a Health Services Research Fellow at the University of Michigan, also a resident physician in general surgery at the University of Illinois Hospital and Health Sciences System. So, Dr. Gonzalez, first question is, just to make sure I fully understand what this is saying, I understand that when somebody has a complication from surgery, more things need to be done. Therefore, the total number of dollars of profit may increase. But did the study say that the profit margin, the rate of profit, also is higher when there are complications?
Yes, that's true. So they looked at two measures of margin. They looked at the total margin, which includes both the fixed and the variable costs, and then they looked at the contribution margin, which is just the per patient variable cost. So in both instances, the profit margins increased for especially for private payers.
Okay, so the other thing that I didn't see in the different articles about this study, but maybe it was in there, was when we talk about a surgical complication, I could imagine situations where there are complications that arise from medical error, right, physician error, or simply that some percentage of patients are not going to recover or have kind of the most straightforward course of treatment that others might have. So did this study apply to both of those? Was it only medical errors, or how was that?
Well, yes, a very good question, David. So when you're looking at errors after surgery, a lot of people don't tease out the difference between a bad outcome and error on the part of the hospital or the physician.
Exactly.
So the outcomes that they looked at specifically were surgical site infections, wound dehiscence, pulmonary embolisms, heart attacks, strokes, being on the ventilator longer than 3 days. So when you look at these outcomes, the problem is that a lot of them, unlike a retained foreign object like leaving a sponge inside of the patient, can't necessarily be attributed wholly to the patient or wholly to the physician. Some things are partially a measure of patient status. For instance, people who have diabetes have higher rates of surgical site infections.
So then it makes it a little difficult to kind of parse out what a solution is, because if we were talking only about situations where there are medical errors, right? In those cases, it would seem that it does not make sense for hospital profits to go up, for the hospital essentially to be rewarded for something that could have been avoided if they did the procedure correctly. But we're talking about both situations, right? Also situations where, because of the patient's circumstances, they may be more prone to complications. So given that, what's your assessment of this? I mean, what can we deduce? What are we to take away from the fact that profit goes up when there are complications? And then we can kind of talk about what maybe would be changed. But what should we be really taking away as the problem here?
So I think that our system of medical payments probably needs to be modified. One thing that was passed under the Affordable Care Act was what's known as bundled payments. So under this payment systems, they basically give the hospital a fee for the episode of care, and whatever the hospital does with that money is left more or less up to the hospital. So they're not paying for individual operations. So the hope of this is that when they give these episode payments, that hospitals will end up reducing costs while increasing quality.
So that would be, for example, somebody comes in for an appendectomy, and regardless of what eventually needs to be done to get that patient out of the hospital discharged, there's kind of like a set amount that I guess would depend on the patient's age and maybe some other kind of variables that would determine what is kind of the total payment you'll receive. And then the hospital in that case would have a higher profit margin if they have a good outcome with less complications. Is that right?
Yes, that's absolutely correct. That is the basic idea behind payments that are based upon episodes. Sometimes there may be like a severity modification. So if you come in with like a ruptured appendicitis, then the hospital may get more money because they're associated with more complications and more care. But that's the essential idea.
So I like the idea of kind of incentivizing proper care from the start, and kind of the not doing this thing where for everything you can add to the bill, you're making more money. That I like. But my concern is, could you not have a situation then where the hospital may not provide the care that, not the bare bones minimum. All of that would be done, but you might have certain situations where the hospital skimps because they know that what they're going to receive is fixed, and there may be ancillary care or things which may be done otherwise that the hospital would avoid doing to not kind of shortchange themselves. Is that possible, or would the fact that those things would be more likely to result in complications kind of be its own safeguard?
Right. I think you have an inherent feedback loop in the bundled payment mechanism, because if something truly improves outcomes, hospitals are incentivized to go after this signal of quality. So, for instance, rehab after surgery. In cases where patients really need rehab after surgery, hospitals would be much more likely to provide for it, even if it's an additional expense. Plus, the bundled payments only covers a limited time after surgery. Right now, I believe the incentive programs are for 30 days after and 3 days before. So depending on that, you may end up winding into a new bundle. So for instance, postoperative care, if you had a longer course that was more complicated. But under these systems, the quality is what's being incentivized. And in theory, the hospitals have no incentive to skimp on services that are essential for patient care.
So give us an overview of where is this type of payment system being implemented currently? Where will it be implemented?
So currently, it's in the pilot phase. In 2015, if my memory serves me correct, it gets rolled out outside of the pilot phase. So basically, right now, it's a opt-in system. Unfortunately, some of the pilot data may not be widely generalizable, because obviously health systems that are vertically integrated, that have all different types of services, are much more likely to be able to make use of this. If you're kind of a single community hospital that doesn't have a rehab, that only has limited surgical services, it becomes much more difficult for you to bundle payments relative to something like Geisinger or the Mayo Clinic or any integrated health system.
Well, it makes perfect sense. Let's incentivize proper treatment from the start and reduce complications. I think the next conversation we have, Dr. Gonzalez, should be, why is it $440 for me to see a urologist for 75 seconds? But that's probably that's a much broader conversation we probably don't have time for today, right?
Absolutely. That is a topic in and of itself.
All right, we've been speaking with Dr. Andrew Gonzalez, Health Services Research Fellow at University of Michigan, also a resident physician in general surgery at the University of Illinois Hospital and Health Sciences System. Thanks so much for talking to us about this today.
Thank you so much.